Intro to Women's and Maternal-Child Health. In this module, we'll discuss the current state of maternal-child health in the United States. Women make up greater than 50% of the U.S. population. So even if you are saying, I have no desire to work with pregnant women, work in labor and delivery, postpartum, or newborn, as a nurse, you're going to encounter caring for a woman. And this approach should be a holistic approach where we're considering all factors, not just physical presentations, but considering mind, body, spirit, and other outside determinants of health. During this course, we're going to talk about caring for the woman across her lifespan. So starting with the first menses, including family planning, preconception, pregnancy, birth, postpartum, caring for the newborn, up to that first 28 days of life, and after, all the way through menopause. It's important to know that to have healthy adults, it must begin with health promotion of the childbearing woman and her family. Caring for the maternal-infant dyad is unique when you think about or when you compare this combination to pediatric or general adult care. For example, when caring for a woman in labor, we are very cautious of the timing of narcotics because the side effects or the effects of the narcotic not only impacts the mom for pain relief, but also has an impact on the unborn fetus as far as respirations, fetal heart rate, and what happens at the time of delivery. So when we think about caring for the maternal-infant dyad, we have to keep in mind that there's two patients who we are caring for. Continuing with the uniqueness of maternal-child nursing, I wanted to focus a little bit on ethics. Here you'll see two articles or links to two articles that talk about the current Wisconsin's cocaine mom law. I want you to read these articles and then go into the discussion and choose a side for or against the law and give rationale for why you chose one side over the other, and we'll have a discussion. There's some basic concepts that you should understand when caring for the childbearing family. Most importantly, know that caring for the childbearing woman is inclusive of her family. And family is however she defines it. It should be a personal and cultural experience, and that knowing that health care during the childbearing period has an impact on birth outcomes, which will have a future impact on that woman and the child that was born. There are 10 principles that nurses and other healthcare providers should be aware of when attempting to provide family-centered maternity care. First, childbirth is not an illness, and therefore we shouldn't approach it as such. Next, we need to be active in meeting the psychosocial, educational, physical, spiritual, and cultural needs of the woman and her family. We have to encourage the woman to be an active participant And in this day and age, patients are going to demand to be actively involved in their care. We want families to have the birthing experience they desire in a clinically safe and supportive environment. That includes providing the family with all the information that they need in order to make informed decisions. And there needs to be continued involvement of the support persons the mother acknowledges. Even though there are various settings in which women can um, give birth, including homes or birth centers, the majority of women in the U.S. still deliver in hospitals. And the way that we have developed protocols um, for women in labor have evolved over time. One including support persons who is allowed to stay in the room with the mom. And that has changed. It has gone from no one being in the room, including the fathers of the babies, to now including whoever the mom chooses. But the key with that is support. The person who is in the room has to be supportive of the mom. We've changed the way that nurses are caring for moms in the maternal child units by we've moved from, in most cases, from having separate units. We used to have a labor unit where a mom would labor and deliver, and then she would be moved to a postpartum unit. Hospitals are changing and moving to units that are combined to provide consistency in staffing whenever it's possible. And you may see things called LDRPs, labor, delivery, recovery, and postpartum, where the mom and her support persons will labor, deliver, and recover and continue her postpartum care in the same um, room. Our roles in is changed to a facilitator. We want to prepare these families to take their newborns home. And so we use and integrate the mom and help her and her support persons to be comfortable in caring for this newborn. And so we facilitate the care. We don't take over the care. We involve them in the care of the newborn and of herself. Here, I just want you to be aware that in addition to normal patient bill of rights, again, with the uniqueness of caring for or making decisions for two individuals, the mom in maternity has an additional set of bill of rights. And here's a link to that, and you can look at that on your own. As you know, as nurses, we don't do it by ourselves. There are other players involved in the care of women throughout the lifespan, including during pregnancy. So we have physicians, anywhere from a family practitioner to specialists, perinatologists who deal with high risk pregnancies, neonatologist who deals then with the high risk newborn, pediatricians, um, certified nurse midwives who are nurses who have gone on to get specialized education in midwifery and have obtained certification. Certified midwives have the same certification as nurse midwives, but they do not um, have education in nursing. And then we have other advanced practice nurses who can be involved: clinical nurse specialists or nurse practitioners, neonatal practitioner, pediatric nurse practitioner, women's health nurse practitioner, and family nurse practitioner. And then we can include all other aspects, other disciplines as well, depending on the needs of the woman and her family. And so the point here is to know that we will be working in collaboration to have and to produce good birth outcomes. Here is an extension of the providers that we would work with in an interdisciplinary manner: social workers, childbirth educators, lactation consultants, and doulas. And as you can see by the asterisk, registered nurses can be prepared in these functions and roles as well. As you will see in the next couple of slides, there are some challenges in perinatal care. In the US, we have issues with birth outcomes, looking at mortality, specifically infant mortality, and the racial disparities and inequities involved in that, providing access to culturally competent care. And culturally competent care is not just based on race, it's based on other social determinants of health, in that we can't, again, have a one script fits all type of care for women and their families. Provider and birth setting options, using evidence-based practice, translating what we know from the evidence in the literature through research and translating that to the bedside. And when we get into caring for women during pregnancy and through labor, we'll talk about how we haven't made those translations quite yet. With these challenges, as a nation, we've set forth goals. Healthy People, if you're not familiar with that, is a national initiative in where healthcare providers, government have come together and develop goals for the nation in various categories. And these goals are a 10-year long goal. And at the end of every 10 years, we reevaluate to see if we've met such goals and then set new goals for the next 10 years. So we're coming up on the end of these Healthy People 2020 goals. And for Maternal-Child, we had goals of decreasing infant mortality, decreasing the number of low birth weight, and very low birth weight infants, the rate of preterm births, those are babies who were born before term, decreasing the C-section rate for low risk women. And we also have goals to increase women receiving early and adequate prenatal care, increasing the use or the abstinence of use of harmful substances, increasing the number of babies who are breastfed, and increasing the length of time that these babies are breastfed. So there's a lot of work for us as nurses to do to help reach these goals. On the next two slides, you'll see that having a baby is expensive. And depending on the type and the setting of the delivery, the price can go up. And even though these rates are um, old 2011, the trend remains the same, that there isn't a decline in the national average of the cost of having a baby. And we'll talk about the importance of that because as a country, we spend the most on healthcare, but our outcomes don't reflect that. One of the challenges that we talked about earlier was infant mortality rates. Infant mortality rates is the the number of deaths within 1,000 live births. So, how many babies in a 1,000 group die before their first birthday? So, when you think about infant mortality rates, it's not based on population size because 1,000 births in the US is the same as 1,000 births in another country. So, we're looking at for every 1,000 births, how many babies die before their first birthday. And as you can see in this graph here, that the U.S. As a nation falls below other countries, developed countries that are similar to ours, where we have a rate of 6.1. So um, for every 1,000 births, 6 babies don't make it to their first birthday, which may not seem like a lot, but when you compare us to other countries and knowing that we spend the most on maternal child care, we should expect better outcomes. Now, when we look at infant mortality rates, and if you look down at the closer to the bottom, you see the United States at 6.17. Japan is down at 2. China is at 14.79. But go down underneath China and you'll see Black America. You'll see African Americans as a race has just about double the number of babies to die before their first birthday than the country itself. So now you can see when we start to peel back the layers that as a country, yeah, 6.1 may not be horrible, but when we start to peel back and we look at individual races, we have a problem. If you have a race of babies that are dying at double the rate of the national rate, that's an issue. And so, how do we as nurses have an impact on decreasing that rate, closing that disparity between um, African American babies and the country as a whole? Because you can, if you look down further under the United States, if you see Caucasian Americans, they have a less rate than the country as a whole. On this slide, you just see that there, when you account for education, infant mortality rates, there's still a disparity. So even if an African American woman has greater than a high school education, her likelihood and the rate of death of her baby is still double, almost triple that of her Caucasian, Asian, or Hispanic counterparts. So it's not education alone that is causing these disparities. And so that is what we're working to find out what other social determinants of health, other things that impact this woman and her family and this infant that's causing this great divide. So we've taken a look at infant mortality rates on a national level. This slide brings us a little bit closer to home. And you can see that the rates for infant mortality, the disparity in particular between African Americans and Caucasians is almost triple. For every 5 babies that die, Caucasian babies that die, 14.6 African American babies die per 1,000 births. And the rates for babies in Racine and Kenosha are worse than they are in Milwaukee. So what's the problem? And how do we fix it? So first we have to understand and grasp the concept of health disparities. So when we speak of health disparities, we're talking about health differences that are closely related to social or economic disadvantage. So when you hear terms or the term social determinants of health, these are things that impact one's health outside of race and ethnicity. So we're talking about economics, we're talking about education, we're talking about racism, we're talking about a multitude of things that can impact one's health. So for example, those with lower incomes typically have poor health outcomes. And note that health disparities adversely affect groups of people who've experienced greater socioeconomic obstacles to health. Two other terms that help us to explain health disparities or gaps between populations regarding health outcomes is inequality versus inequity. Now, you may find that people use these terms interchangeably, but they have very stark differences. According to the CDC, health inequality is the differences or disparities in the health outcomes of an individual or group. For example, there's a clear difference between infant mortality rates between African Americans and Caucasians. That's a disparity. And the outcome would be infant mortality rates, right? However, inequity is a difference or disparity in health outcomes that's systematic, avoidable, and unjust. So the reason why there is a disparity could be caused by an inequity. So try to give you a visual of explaining that. So equality is that everyone gets a box. Everyone gets access to health care, right? But the inequity realizes that some people don't need access. They already have it, whether it's because of socioeconomic status, whether it's because of education, that they don't need assistance with that. Equity spreads out the need based on the need. So in our pictures here, everybody gets a box in equality. It's equal. Everybody got a box. And then you can see equality isn't always just. So there has to be some equity along with that equality. Here's another example. We know that there's a disproportionate number of poor minority citizens in the U.S. that don't have adequate access to health care. Is this healthcare inequality? Yes, because there is a difference, right? There is a clear difference in the rates of access to healthcare among different segments of the population. Now, is it a health inequity? Huh. It depends on whether your idea of just involves the right to health care, right? If you believe that health care is a right to every citizen, then your answer would be yes, this is a health inequity. That it's unfair and it's unjust that there is this fundamental difference or this clear difference in access to adequate care. If you believe differently, then you would think that this is not, or you would believe that this is not a health inequity. There's been a lot of research on looking at social determinants of health that may impact health disparities in this country. In particular, Dr. Liu out of California has developed what he calls this life course perspective that starts in utero. And his theory, in a nutshell, is that stress, persistent stress over time, has an impact on a woman's health, including the outcome of her birth. So he gives an analogy at stress is like pushing the gas on a stalled car. That if you're constantly putting pressure on that engine, that over time it's going to start to break down. And so he gives different things like stress, abuse, the use of drugs and alcohol, poverty, lack of access to care. Those things accumulating over time, starting at birth, will impact women, and particularly African American women, more greatly than their Caucasian counterparts. When we are caring for women throughout the lifespan, it's important to consider cultural beliefs and values, right? We have to not only look at ethnicity and race and know that there are differences between and within different races and ethnicities. For example, all African American women do not have the same values and beliefs. It's based on generations, it's based on geographical location, based on socioeconomic status, it's based on education. And so when we start to talk about cultural awareness, cultural competency, we have to be clear and careful that we're not generalizing, putting everybody in one box. We also have to consider our veterans as part of a culture, veterans who are now returning back to civilian life. What implications does that have for us as providers when providing care for women veterans? So there's a couple of terms to become familiar with in relation to talking about cultural awareness, cultural competency. First term is acculturation. When we think about acculturation, it is adopting the culture the values, beliefs of the dominant or majority population while still maintaining some of your original culture, values, and beliefs. The next term is assimilation. When one assimilates, they completely let go of their original cultural values, beliefs, and immerse themselves in the dominant culture's beliefs and values. Ethnocentrism is the belief that one's culture is the best and that there is no thinking or giving any thought to any other culture. So the belief that Western medicine is the best way to treat a particular disease without considering Eastern homeopathic types of treatments. And we can see that this can be a problem in healthcare, especially when we're dealing with diverse populations who may not have assimilated to Western values and beliefs. And so that belief that our way is the only right way can bring problems. Cultural relativism is the opposite of ethnocentrism. Cultural relativism is the acknowledgement and belief and the integration of other cultures, knowing that other cultures have their differences in beliefs and values, and acknowledging and bringing those to the table. Subculture is a culture within a majority culture. And I gave an example of that on the previous slide, that there are subcultures within different races or ethnicities based off of various different things. Continuing with culture, we have to recognize that there's patterns that exist within cultures and subcultures. And there's patterns in childbearing behaviors, for example, tolerance or acceptance of pain, preferences for providers, and that as nurses, we have to first acknowledge our own moral values and beliefs, acknowledge any biases that we have because we all have them, but we have to avoid stereotypes, meaning that we're taking a snapshot of what we've seen via media or what we've heard and applying it to an entire population. We have to acknowledge that we may judge, because if someone has different values or beliefs that we do, especially when we're talking about women's health and we're talking about health issues, for example, contraception, whether to use them, whether not to use them, pregnancies, if you believe that a woman should not get pregnant until she's married and you work with teens, you have to avoid judging that client and their situation. And we take from each woman and her family, because each situation is going to be unique. And we build on those things and we reflect on those encounters to help us with the next family. Lastly, I wanted to just touch on families, because we don't just take care of the woman, we take care of her family. And that is however she defines it, right? And so we know that in the US we've evolved or expanded on the types of families that exist. It's no longer just the nuclear family where there is a mother, a father, and kids. We have extended families, We have blended families where there are children from two different marriages and parents now have come together. We have families that have multi-generational, and this could be related to culture, who are involved in the family decisions, including health decisions. We have cohabitating parents, parents who live together who are not married, single parents, and homosexual same sex families. And so we have to know that family is how the woman defines it.